Oh, yeah, for sure.
Okay, guys, let's go ahead and get started. Okay, so last class we were talking about when good gallbladders go bad. So when good gallbladders go bad, what happens? What's the 2 ways that the gallbladder can go bad? Crickets. I made these. What does the gallbladder make? Stones. Stones is one way that the gallbladder goes bad, right? Makes them into bile salts so we can actually give medications to absorb those bile salts to ideally disintegrate the gallstone, right? Now, we said the gallbladder is a bag that holds bile. It's a muscular bag. So what's the other way that the gallbladder can quit working? What?
A disease.
Not necessarily a disease, just what happens.
You're referring to it holding on to everything and not releasing.
Yes. Okay. The gallbladder can hold on to everything and not release the bile when it needs to be released.
Hepatic lipidosis in cats. Unfortunately.
Yes. Yes. Mm-hmm. Absolutely. Okay, so with this gallbladder, when it goes bad, it's either going to be stones or the muscular bag is not squeezing out the bile to help break down. What does bile break down? Fats, right? Okay, so it's not squeezing appropriately to be able to break down the fats. So to be able to see the gallstones, what kind of diagnostics do we do?
Was it ultrasound level?
Ultrasound, yes. Ultrasound, we could do CAT scan. We might be able to see them on an x-ray. Maybe, maybe not. Okay, so after we've done the ultrasound and we find that we don't see any stones, what's our next step to check the bag to see if the bag is squeezing? Starts with H. Hydroscan scan. Very good. So it's the hydroscan scan that actually will check. It's a nuclear test that will actually check to see if the bag is working. Now, when we talk about the gallbladder, what's classic gallbladder pain? Where's it going to be at?
Isn't it?
Right shoulder and substernal over on the right side. Okay? And it penetrates through to the right shoulder blade. Now, its next door neighbor, the pancreas. When the pancreas goes bad, where is classic pancreatic pain? Substernal and left shoulder. Okay? So when the gallbladder's bad, you can end up with pain in both shoulders because the pancreas gets upset too and starts hurting. Okay? So when the pancreas is messed up, you have to take pancreatic enzymes. What are those enzymes for?
To help break. No, they're not.
You're very close.
I was thinking of the thing we were just talking about for that, to break down the stuff. The enzymes are to.
The enzymes are to break down the different types of food. Mm-hmm. So amylase breaks down bread. Okay, lipase breaks down fats. And protease breaks down proteins. So you go to Texas Roadhouse, you get brought out this big thing of bread that's scrumptious, and it has that big gooey butter that goes with it. So you dip the bread in the butter, you put it in your mouth, and what starts to happen in your mouth with that bread? Doesn't it start to break down in your mouth? Okay, so there's receptors within the mouth that says, hey, Honey butter's coming your way. So that's going to send a message that we need to get ready to break down lipids. And so that prepares the pancreas to start dumping stuff to break down different food products. So if the pancreas isn't working, are we able to digest foods? No. So big thing with pancreatitis, you're going to be very, very nauseated. You're going to be puking up water, not being able to keep anything down. Pancreatitis is associated with eating rich foods and alcohol consumption, right? So these enzymes, when we have to replace these enzymes, there's a couple of big points that we need to make sure our patients are educated about. Do these enzymes, are they smart enzymes that only break down proteins that's in the steak? No, it's going to break down any protein. Guess what your mouth is composed of? Proteins, right? And so your mouth being composed of proteins, then what does that mean? What will these enzymes do? They're going to break down your mouth too. So you've got to make sure that when the patients you put the enzymes in a large cup of water, and that makes sure it doesn't get stuck breaking stuff down along the way. You chug this water that has these enzymes in it, and then do you want to leave the residue in the patient's mouth? No, because what will it start digesting? The mouth. Okay, so you need to be sure to wipe the lips, take a drink, swish it around, spit it out to keep these enzymes from breaking down tissues that are not supposed to break down. Okay, now pancreatic cancer. Is it on the top 10 ways to die? It's a very painful, very, very painful death. So no, I would not prefer to go this way. Pancreatic cancer tends to be associated with what consumption? Alcohol. Okay, so do we find out about pancreatic cancer early or late? Late. It tends to be too late for us to be able to do anything about it. Okay? So with that, pancreatic cancer, you're not able to eat anything. You start getting very anorexic. The symptoms are so vague and insidious that it's hard to diagnose. You feel like crap. Well, how many other diseases make you feel bad? Just about everything. So it's really hard to pinpoint. And usually it's found kind of accidentally because they'll be doing scans to figure out why you're feeling bad. And then, oh, pancreatic cancer pops up. Okay. So then we have to either remove the pancreas and then we're losing insulin. We're losing the ability to secrete glucagon, right? Glycogen stores. And so we have to really watch our sugar because your sugar gets very, very brittle at that point. Okay. Any questions from last time? Crickets. Okay, so today we're talking about when the liver goes bad. Now, when the gallbladder goes bad, it's going to irritate its next door neighbor, the pancreas, right? Who's its other next door neighbor? The liver. What's our liver's job? Filter. So what's our other filter system in the body? The kidney, right? Okay, so the liver and the kidney work together, right? And they both filter. Now the liver has other jobs. it makes the cholesterol that your body needs, or rather adds to the cholesterol, because as the American diet has way too much fats in it anyway. So we have to take these medications. What class to break down cholesterol? Statins. Okay, so with statins, we take those to help turn down the liver on making cholesterol. The liver also does what? Makes what protein? That goes in the blood. We talked about it's the principle. Albumin. It makes albumin, dumps it into the blood, and then the water leaves third spacing to come back into the blood. So we're able to actually filter it through the kidneys and get rid of it then. Otherwise, the water doesn't want to stay in the blood. So we may have to give albumin, because with liver problems, we're going to have third spacing. What do we call the third spacing when it's around the belly? Ascites. Okay, so with that, how do we get that fluid out? We can either use diuretics, albumin, or diuretics and albumin, or we can do a paracentesis where we go in and we tap it and drain the fluid off. That is one of our last resorts, because once we start doing the body's job for it, the body says, I'll let you do it. So once we tap them, you have to continue to tap them with a paracentesis. So we want to do everything we can prior to that. Okay, so also the liver makes clotting factors. And so it's very involved with bleeding and control of bleeding. And the liver, we've talked about this with the kidney. When you eat protein, it gets broken down into nitrates. Nitrates, two nitrates put together make an ammonia molecule. So the liver will package ammonia molecules together to make urea. The kidney can't just get rid of ammonia. It has to be in the form of urea for the kidney to be able to get rid of it. So if the liver isn't working, then what happens to the ammonia within the body? Can it get out of the body? No. So what happens when the brain is floating in ammonia? What happens to behavior? Confusion, altered mental status, behavior change. Okay? It can look like a stroke because it will affect the way the nerves work as well. Okay, and then last review thing. What do we call it when the hands start trembling in a flapping motion? Liver flaps. What's the fancy word for it? Asterisk. Okay. Okay, so as the liver's having problems, that's one of the signs that you look for with patients, and to notice if there's problems with the liver. Okay, so we've talked about this. The liver detoxifies. The liver makes bile. And the liver helps to regulate fat-soluble vitamins, because remember, it makes the fats. Now, what were our fat-soluble vitamins? A, D, E, K. ADEK. 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 Okay, so, and we talked about the liver's role in managing glucose as well. Okay, when good livers go bad, the liver should be very, very smooth. And there's actually two chunks of the liver. So we can actually take out the smaller chunk, put it into another person, and that liver will grow and reproduce to the entire full size that it has available to. Okay. So as people, if it's a child that's needing a liver transplant, that liver will continue to grow with the child. Okay, so cirrhosis is going to happen when the liver is no longer smooth and very vascular. It's going to get rigid, filled with scar tissue, and lumpy, chunky. So as the good parts of the liver are literally being replaced by scar tissue, that's what makes it hard. Is the liver able to make what it needs to make? No. Okay. So the tissue becomes nodular, makes it lumpy, chunky. Okay. The nodules, as it gets rigid, it starts to block blood flow and lymph flow. So as the blood is being blocked, what happens to the liver's job of filtering? If it's not getting blood, is it filtering it? No. So we start to run into multiple problems. And the liver is going to get hard and be replaced by scar tissue. So it shrinks as it gets hard. And the reason it's getting hard is because it's lumpy, chunky, and it hardens with scar tissue. So we have several types of cirrhosis. So post-necrotic. Can we do things to our bodies that cause the liver to die? Yes.
Without the alcohol.
Without the alcohol, absolutely. So then we have alcohol. If we marinate the liver in alcohol, guess what we're doing? Have you seen jars on NCIS that had body parts in it? We basically are fermenting the body parts. So the liver, as the body is soaked in alcohol, it becomes overwhelmed and it can't do its job. Now, the last part is called biliary issues. This is going to be due to vascular issues within the liver. Now, whenever you see biliary, you need to be thinking of liver. Okay? So complications. If we mess with the vasculature of the liver and we're creating scar tissue and we're creating backups within the blood flow, what's going to happen to those blood vessels? They're going to be getting rigid too, right? So are you going to be able to get the same amount of blood through those blood vessels as the liver needs? No. So it's going to be under higher pressure. So we have portal hypertension. Portal hypertension means high blood pressure of the liver. So as we have too much pressure within those vessels, what is going to happen? What is going to happen to the blood vessels themselves? Are they going to try to stretch? Yeah. So, does your mom or your grandma have varicose veins? You know what varicose veins are? It is from stretching of the blood vessels within the legs due to gravity. And so what happens is these vessels stretch, and as they stretch, you start to see the lines on the outside. Well, we can't see the blood vessels that are right next to the esophagus, but what we do know is that with portal hypertension, these vessels stretch. Once the vessels stretch, are they at greater risk for popping? Yes. So around the esophagus, the blood vessels start to stretch, and this makes esophageal varices. It's literally varicose veins within the body. Okay? So these blood vessels are more fragile. The liver isn't working right, making clotting products. How easy is it for me to put pressure within the esophagus to stop the bleeding? Not easy at all. So what happens if these pop? Your patient is going to die from hemorrhage. They are not going to make it to surgery. Okay, so this is esophageal varices. The ascites we're already familiar with. Biliary obstruction. What if the gallstones are blocking the path to the liver? Okay, so that creates problems with flow, and things can't get out of the liver. So that creates havoc within the body. So encephalopathy, hepatic encephalopathy, that's due to ammonia, right? Okay, so hepatic encephalopathy is due to the liver's inability to put ammonia into what? Urea that can be gotten rid of by the kidney. So we can also have cirrhosis from hepatitis. Now, there's a bunch of different hepatitis viruses, okay? And we'll be talking about those here in a minute. But hepatitis C, hepatitis cancer, okay? Hepatitis C is one of the biggest causes of liver cancer. Now, liver cancer is not on my top 10 ways to die either. It's a long, slow, painful way to go, okay? And so the leading cause of cirrhosis and liver cancer is what?
C.
C. Okay, do we have a vaccine for Hep C? No, not as of this point. Do we have a vaccine for Hep A? Yes. Do we have a vaccine for Hep B? Yes. We don't have a vaccine for any of the other hepatitis. Now, they aren't very creative when naming hepatitis. A, B, C, D. We're actually up to G at this point, but we're not going to ask you to know about all of it. I want you to know up to E. Okay? Hep A is fecal oral transmission. So what populations are going to be most at risk? Who can't wipe their butts well?
Who puts their hands in their mouth?
Who puts their hands in their mouth all the time? Little kids and older people. Okay? So hepatitis A tends to run rampant in daycares. Again, there is a vaccine for this. Hepatitis A runs rampant in nursing homes and in daycares. Fecal oral. Okay? Hepatitis B, blood and body fluid. You're all pretty familiar with hepatitis B. You had to have shots before you got into nursing school. If you have hepatitis B, you are more likely to get hepatitis C. So do we have a vaccine for C? No vaccine for C, only for A and B. Hepatitis D is blood and body fluid as well. Hepatitis E is fecal oral transmission. Okay, back
You said E was.
Fecal oral. Okay. A few years back, we actually had a hepatitis A outbreak at O'Charlie's down in Turkey Creek. So people started dropping like flies with hepatitis A infections going to the emergency department. And with that, when there's all of a sudden a bunch of people who aren't fitting the normal pattern, because who gets Hep A? Young and old, right? Well, now there's these teenagers coming in, there's these middle-aged people coming in with hepatitis A, and they're trying to figure out where it comes from. So that's the epidemiology department at the health department. That's their job. So they go through and interview all these people. Well, where have you been? Where have you eaten? What have you done? Church picnic, etc. Okay. And what they found was it was with O'Charlie's at Turkey Creek. And so then they start going back, going, okay, what did you eat at O'Charlie's? And trying to match up, what did everybody have in common that got sick? And so it turns out, long story short, anybody who got a cold drink became infected with hepatitis A. The ice. So, digging deeper, what's going on with the ice? Well, they had an employee who had gone on a mission trip to Guatemala. Guatemala has large amounts of Hep A? Absolutely. So he came back with the gift that keeps on giving, hepatitis A, and he was pooping like a goose, and medical terms, of course. And so with that, he tried to call in. I'm sick. Well, the restaurants, do they really care if you're sick? No, not so much. He had just been off for 2 weeks to go to Guatemala. So they said, come in or else. So he came in all right. And he was still pooping like a goose. And his job that day was to fill up the ice dispensers. And he hadn't washed his hands well. So with that, the health department started up a phone line and started up locations where if you ate at this restaurant between this time period, then you need to come in and get antibodies. The antibodies will stop you from getting sick or make it less severe. Okay? If you hadn't eaten at that restaurant, would the antibodies do you any good? Had you been exposed to Hep A? No. So the antibodies won't do you any good. Okay? So with that, the vaccine is for prevention. Treating you with antibodies is for after exposure. Will giving you the antibodies hurt you if you happen to not get any of the poop infested ice? No. Okay. Will it stop you 6 months from now from getting infected with Hep A? No. That's what the vaccine's for. Okay. Make sense?
To not eat out anymore.
To not eat out anymore. Don't touch my ice. Okay, so non-alcoholic fatty liver disease. This is just what it sounds like. Your liver, your body has too much fat. One of the places that you squirrel away fat for a rainy day is around your liver. Okay? Now, if you have enough body mass, you will have non-alcoholic fatty liver disease, even without drinking. So this is associated with obesity, diabetes, metabolic syndrome. Now, what was metabolic syndrome?
Get fat.
I'm sorry?
You get fat.
You do get fat with it, but what else? There's three key factors for metabolic syndrome. Insulin resistance, hypertension, and obesity. Okay? So, alcohol use. You use alcohol enough, then it's going to pickle your liver and give it cirrhosis. Now, when patients come in and they say they've had 2 beers, it is never 2 beers. Okay? The majority of patients lie very profusely about alcohol consumption. So I had a patient come in and he had like severe cirrhosis. And he said, well, I only have 2 shots at bedtime to help me sleep. It's like, okay. So I'm sitting here thinking exactly, was it like the Weigel's Route 44 Muggo Juggo shots? Because you wouldn't get this level of liver disease from 2 shots a day. So guess who outed him? His wife. Because talking to her, well, tell me about how is he drinking? You know, he says he's only had a couple of shots. You know, she just looks at me and her jaw drops. And she turns to him and said, you said a couple of shots? And he's like, well, it may be pints. Turns out he was drinking about 2 quarts of moonshine a day. Okay? That's more fitting with the level of disease that he had. So with that said, you have to talk to patients and make sure they understand that you in fact need to know what they're doing. I don't care if you're using drugs. I need to know if you're using them. Okay? So cirrhosis. With cirrhosis, it's a major cause of death. Again, not on my top 10 ways to die. Things you have to look at. Age. Why would age play a factor in this?
Because your parts don't work as good as you get older.
Your parts don't work as good as you get older. Absolutely. So your parts don't work as good. And could your parts have been exposed to more bad stuff? Absolutely. Okay. So gender. Who's at more risk? Males or females?
Isn't it men for this one? It's
It
always
is
the
men.
It's always us.
Men. Okay. Why? Who can drink more alcohol? Men.
That's why I was guessing women. We can't drink.
Yeah.
We can't go drink for drink.
You can't go drink for drink. But the thing is, the guys can drink more.
Fair.
So it's a dose response kind of thing. The more pickling agent you put in, the more pickling happens. Okay? So it creates scar tissue and makes the liver lumpy, bumpy, chunky. Okay? So employment history. Why would this matter? Toxins. Let's say you work at the John Deere plant and your job is to spray John Deere green. So you go home and you have little John Deere green around your nostrils every day. Could this affect your liver? Could working with pesticides, because you're working in landscaping, affect your liver? Absolutely. Okay, needle stick injury. Now, People will always ask me, well, aren't you scared of working with HIV patients? No. HIV is a wimpy virus. It has to have person-to-person contact to live. If it spends 30 seconds outside of the body, it dries up and is dead. The virus that scares me is hepatitis, because those things are like cockroaches. They will be around after Armageddon has happened. Hepatitis is going to stay, potentially it goes dormant and it stays infectious for months. Okay?
Kind of like C. diff.
Kind of like C. diff. Yes. And think about, again, not to make you feel bad about your desk, but think about who has sat at this desk before you. Were they picking at their cuticles and ended up bleeding?
Did they wash their hands like the Iceman?
Or did they wash their hands like the Iceman? Or lack thereof? Yeah. So with that, this is why schools will shut down just to clean during flu season. But hepatitis, you can get infected by hepatitis with smaller doses. One virus particle can be infective and cause you to get infected. HIV, you have to have a large number of viruses to be able to make it alive into the body to be infective. So hepatitis is the big thing that I'm actually concerned with needle stick stuff. Okay? So, history. Why would sexual history matter?
Because you just said person to person.
Okay, person-to-person contact. Blood and body fluid. Family. Who you live with. Now, with this said, is it okay for me to take a shower in the same shower that somebody who had Hep B was in? Yeah. Would I use their razor? No. Okay. Now, alcohol withdrawal. Alcohol is the only substance that you can die from withdrawal, because it turns off the inhibition in the brain, the GABA in the brain. Because you're getting so much external GABA. GABA is what makes beer goggles. You're getting so much external GABA that your brain says, I don't need to make it anymore. So when you take that away, your brain doesn't know how to calm itself down. You end up with seizures. And you end up with too much excitatory stuff. That's the reason they tremor. Because they don't have any of the inhibitions. Okay? So, with cirrhosis, we've talked about ascites, we've talked about blood issues, we've talked about, and the blood issues, where do the blood cells go to mature after they're released from the bone marrow? That's some cobwebs off. The spleen. So if the spleen is having to work extra hard, what's it going to do? I go work this muscle extra hard, what's it going to do? Get bigger. Splenomegaly. Okay? So testicular atrophy with cirrhosis, your testicles also shrink. Leukopenia, what's that? Not enough white blood cells. So what's going to happen to your risk for infection? Your risk for infection is going to go up. Can I be in crowds?
No.
No. Very good. Okay, esophageal varices. This is what we've talked about. With esophageal varices, the blood vessels get larger. As the blood vessels get larger, they get weaker and they're more prone to breakage. And that breakage causes bleeding. So lab assessments, what are we going to be looking at? Looking at liver panels. That's going to be AST and ALT. LDH is lactic dehydrogenase. Okay, that's going to be lactate is when your muscles do anaerobic respiration, right? Produces lactate. Now, I'm sure you've heard of sepsis and lactate. Now, when you draw lactate and you draw an ammonia level, how do they have to be sent down? On ice. Why? They'll continue to deteriorate and you'll get false levels. Okay? So you want it on ice as soon as you draw it. Alkaline phosphatase, GGT, is an indicator of liver issues. Serum means what? Where's it coming from? Blood. Serum bilirubin. Where should your bilirubin be going to get out of the body? What makes your poop brown? Bilirubin. So if your serum bilirubin is high, that bilirubin, which is parts of red blood cells that have lysed or been killed, if your serum bilirubin is high, what color is your poop going to be? Clay colored. Okay? Clay colored stools. Serum albumin. Why would I care about that? Edema. Third spacing. Absolutely. PTINR. Why would I care about that? Clotting, because the liver is involved in clotting. CBC, because of leukopenia. Ammonia levels. So what are we going to do? We're going to be doing x-rays, CTs, to be able to see what's going on. CT and MRI is how we're going to be able to see esophageal varices. Do you need me to move, Roberto?
No.
Okay. Other diagnostic stuff, you're going to be doing ultrasounds, a transient elastography. What is that? What do you think it is? Have you heard of elastic? Yes. It's looking at the stiffness of the liver. Because as the liver shrinks and gets rigid, is it going to stretch as well? No. Okay, so if we're looking at the blood going into the liver, we would do an arteriogram. Looking at an EGD, what's that? A scope. Okay, so ERCP, this is where we're going to be looking at crushing potential obstructions. Okay, let's take a break and we will come back in just a minute. Okay, so understanding paracentesis. This is where we stick a needle in to drain the fluid out if all other ways to get rid of the fluid have been exhausted. Okay, So again, once we start this, then we have to continue doing it. What are going to be some risks for paracentesis? Infection. I'm sticking a hole in that wasn't there previously. Okay, what about if we pull too much fluid off? Can we cause electrolyte shifts that we didn't mean to happen? Absolutely. So what will happen is people will have to remain in the hospital and we'll have to tap them on different days to be able to get the needed amount of fluid off using paracentesis. So why would I want to pee before I have a paracentesis? Do I want to accidentally poke the bladder? No. Do I want my patient to go, I gotta pee while I got a needle in them? No. So let's just bite the bullet and make them go ahead of time. You don't gotta go, but you gotta try. Okay, so more importantly than just fixing the fluid is that we figure out what's causing the fluid to be in excess in the first place, and that we fix the actual cause of the fluid management problems. So with this, we have to worry about fluid overload. We have to worry about electrolyte shifts. We have to worry about bleeding, both because the liver makes clotting factors and that esophageal varices put you at greater risk for bleeding. Okay. We have to worry about mental status changes, high ammonia levels, because ammonia gets converted to what to get out of the body? Urea. Has to be converted to urea to get out of the body. So when a patient is having metabolic encephalopathy or liver-based encephalopathy, hepatic encephalopathy, it can look like a stroke because you're going to see new onset changes and you have to rule out a stroke prior to being able to say that this is what is causing it. Now, if I have bilirubin that's getting stuck in my skin, would that contribute to dryness and itching? Yes. So with liver patients, they itch all the time. One of the things you can do to help is put lotion on, because that bilirubin gets stuck in the skin and creates havoc for that skin. And so that's how we end up with jaundice. The bilirubin is stuck where it shouldn't be. So things we have to do, we have to make sure that they still can be dehydrated even though they have ascites, because the fluid is where? In third spacing, not in the bloodstream where it's accessible. So you have to manage fluid volume. With that said, do I want them to be able to have the largest cup from Sonic in drinks? No. So I need to manage and find the sweet spot in between the two where they're not getting too much fluid that's going to cause more problems, but they're able to maintain their hydration status. Okay. Esophageal varices. We said it's kind of hard to be able to stick your hand in and be able to control bleeding around these dilated varicose veins of the esophagus, right? Well, what can do it is called the Minnesota Blakemore tube. It's the exact same tube. It's called multiple things. Okay. You see a Blakemore tube though, that is for esophageal varices. We shove it down in the esophagus and into the stomach. Your patient is obviously NPO. And what we will do is inflate these different pockets to put pressure on through the esophagus onto the esophageal varices to help prevent them from popping or if they have already ruptured, help to control the bleeding. Okay? So what we will do is we're going to inflate these balloons to hold pressure in different places simultaneously. Okay, now I want you to understand overall how these tubes work, why we would use these tubes, what's the benefit, that kind of thing. We're not going to ask you how many cc's of air should be in the gastric tube. Okay? So this is just to kind of show you how it works. Now, this is what the tube looks like. So we shove it down into the esophagus. And so it's not going to be very pleasant going down. So we often will kind of give patients some Ativan to help them relax with it. Now, do I want to have acid in the stomach with the esophagus blocked? No. So these holes down at the bottom, the gastric aspiration, I can connect this to suction and be able to keep their tummy empty. Because if you're sick enough to require this, you don't need to be eating. You're going to be NPO. So I can suck out all the stuff and deflate the stomach. And that will also help because with this, you're also going to have ascites. And then the ascites, could that make it difficult to breathe? Absolutely. That fluid is pushing up on the lungs. So this gastric balloon, we inflate it and it anchors within the stomach. Okay? And that is actually going to be our largest balloon because we have more area to hold it in place. Okay? Now, then we will inflate the esophageal balloon, and that's what actually holds the pressure on the esophageal varices. Okay, so we have several different ports up at the top, and these are to blow up the different balloons and to be able to connect to suction for the gastric tube. Now, do I want my patient to have this for weeks at a time? No, because it could start to create necrosis from the constant pressure. But it is a really good adjunct in our arsenal to be able to take unstable patients and help make them more stable quickly and give the medical team more time to be able to figure out how to fix it. Okay, so esophageal varices, this is due to portal hypertension. So what's the relationship between regular hypertension and portal hypertension? If you have too much blood pressure, it's too high throughout the body. Remember, the portal veins and portal arteries are so small, it's going to magnify that hypertension. So the higher your regular blood pressure gets, the higher the portal hypertension will get. Make sense? So treating regular hypertension is going to help with portal hypertension and make it less likely for esophageal varices to rupture as well. Okay, so we do this through different antihypertensive agents. It could be through the prills. What are those? ACE inhibitors. Sartans, what are those? ARBs. Okay, it could be through alpha blockers like clonidine or hydralazine, or it could be through our beta blockers. What do they end with? LOL. Very good. So what kind of lifestyle changes would I need to make? Do I want to go out and go drinking on Friday nights? No. Cut the alcohol. What about Tylenol? I would need to cut that as well. And so I also am going to need to monitor CBCs to be able to see how my platelets are doing, how my blood count's doing. If all of a sudden I have a drop in my hemoglobin and hematocrit, what are you going to think has happened? I've got a bleeder somewhere. Okay, why do I want to avoid increasing intrathoracic pressure, like bearing down? If I bear down, what's going to happen to those potential bleeders? They're going to get worse. They could rupture. Okay, so stool softeners, antiemetics. Do I want vomiting to happen? What about coughing? What about bending over and picking up heavy objects? Okay, so you have to make sure that you're protecting the patient from increased intrathoracic pressure. Now, can they have stuff like Doritos? Why? Sharp edges. So the esophagus is right next door to these esophageal varices, and any kind of additional pressure is going to make them rupture. So ways to prevent these. Basically, we've talked about these. Avoid straining. Take medications. Avoid irritating the liver even further. So how do we know our patient's getting better with any of the cirrhoses? We have less ascites. We have better mental functioning. Our electrolytes are good. Our fluid balance is good. They're making more stents. They're able to decrease their ammonia levels. Okay? The poop is going to turn what color? Brown. The things you learn in nursing school. Why is poop brown? Okay, so hepatic encephalopathy we've talked about. It is very severe. It can progress to coma. The brain can be marinating in so much ammonia that it can no longer function, so it shuts down. Non-alcoholic fatty liver. This is related to metabolic syndrome, which we talked about earlier, type 2 diabetes and obesity. Now, non-alcoholic fatty liver disease just means there's fat around it. Non-alcoholic steatohepatitis, NASH syndrome. This is where the liver is actually getting damaged. And as a result of it getting damaged, it's going to cause structural changes within the liver. So it looks like cirrhosis, it acts like cirrhosis, but it's not cirrhosis because it's caused by something entirely different. Make sense? So with this, you assess for risk. You assess the AST and the ALT liver test to see how ticked off the liver is. Take actions, lose weight, eat better, control fats, increase statin doses. Okay. Behavioral changes. Do I want to allow them to still drink? Okay. Now, are they still going to drink? You can't stop it. Okay. Hepatitis. We've already talked about. Hepatitis A is what? How's the mechanism? Fecal oral. Okay. Hepatitis B. Blood and body fluids. Which do we have vaccines for? A and B. Okay. C is most likely to cause cancer. Okay. D, the research isn't there yet because it's so new, but what I suspect is going to happen, bless you. What I suspect is going to happen is that we already know if you have C, you're more likely to get D. And if you have B, you're more likely to get C, right? What I suspect is that D is going to be similar. So you're more likely B, C, and D will hang together. Okay. Now, E is fecal oral. We don't see this type as much in the United States, but if you have somebody who's been out of the country or border states, Mexico has hepatitis E, okay, then you may see it. Okay, food handlers we've talked about. You'll never forget Guatemalan ice. Shellfish can be contaminated. Now, where this becomes a risk is eating it raw. If you cook it to appropriate temperatures, then you don't have to worry about it. You need to be sure to wash your hands after preparing any kind of shellfish, though. Hepatitis B, blood and body fluid, we've talked about. Hepatitis C, we've talked about. D, blood and body fluid, and then E, foodborne, waterborne. Okay. Jaundice means what? Our skin turns from what? Bilirubin. Okay. So jaundice is when our liver isn't able to work right, it gets inflamed and it's not able to get the bilirubin to be excreted in the poop appropriately. Okay. So what color are our stools going to be? Clay colored. Okay. Icarus is usually referred to as the jaundice of the eyeballs. Okay. But Icarus and jaundice tend to go hand in hand. If you are jaundiced enough, your eyeballs are going to start to get yellow. Other common symptoms, you're going to feel like crap. You're going to have abdominal pain. You're going to have dark urine. Where is the fluid going in liver problems? Third spacing. So are you going to be peeing out copious amounts of water? No. So does it make sense that your urine would be dark? Because it's more concentrated. So liver biopsy, why would I want a liver biopsy? To check for cancer. Now, which type of hepatitis?
C.
Hepatitis C is associated with cancer. Okay, and then ultrasounds, the same with the heart. You know how we can do the Doppler with the echo and be able to look at the blood flow? We can do that with the portal vessels with ultrasound with Doppler too. So as your hepatitis gets worse, are you able to metabolize food appropriately? You're nauseated all the time. Do you want to eat? No. You're having abdominal pain all the time. Your stomach is huge from the fluid. What will happen is the person themselves starts to drop weight. The actual weight on their body is the fluid. Now, 2.2 pounds is what? A kilogram. And it also is equal to 1 liter in volume. So how do I determine how much fluid I've lost? One, I measure it doing a paracentesis. Second off, I weigh them. So I can be able to compare those two values. So if my patient has lost 4.4 pounds, how much fluid volume have they lost? Two liters. Very good. Okay, so your body isn't getting the nutrients that it needs. It's not getting the calories that it needs. So what happens to the energy production? Drops. How do you as a nurse need to approach this patient? Do you want to be running in and out all the time? No. Cluster care, plan in periods of rest, because the patient is going to be so profoundly fatigued. So we want to make sure that they're getting the nutrients that they need. And we want to manage fatigue. So help them understand when they're tired, rest. Okay, hepatitis patients. This is very similar to a renal diet. They aren't able to make albumin. So one way we can mimic that is through consumption of protein. However, if I eat too much protein, what happens to my kidneys? Can my kidneys process large amounts of protein? No. Okay, so with this, I want to have a high protein, low fat diet. Now, when I say high protein, I'm not talking about Texas Roadhouse's steak that's bigger than a plate. Okay? I'm talking about the amount of protein that you should be getting in a day is the thickness of a deck of cards, and it's the size of the deck of cards. Now, if you go to Texas Roadhouse and they give you that small of a piece of meat, are you a happy camper? No. So in the American diet, we have way too much protein, and we have made way too much fats and way too much carbs, not enough fruits and vegetables. So the liver is responsible for fat processing of fat soluble vitamins. What were those? A, D, E, and K. Okay. Vitamin K is involved with what? Clotting. Very good. Okay, so do we want to have salt in the diet? No. Water follows salt. If we have salt in the diet, what's going to happen to our fluid overload? It's going to get worse. Absolutely. And we need to make sure that we are drinking enough, but not too much that we end up going into fluid overload. Okay, so you want to stay hydrated, but don't push the fluids to the point that you're actually making the condition worse. So home care management, this is going to be the fecal oral types of hepatitis. Which two were those? A and E. Both of those are usually time limited. Okay? You're eventually going to get better from it. B, C, D, F, G. You have forever. Okay? We can treat the symptoms, but we cannot eradicate the disease. Okay, so we can give some medications that will help lower the viral count. Okay, but it is still there waiting for time periods of being immunocompromised to pop back up. So with hepatitis, we need to help them manage the fatigue, help them get more energy to be able to do their ADLs, to be able to have a life and not just be dealing with the illness. And we need to make sure that we're watching for infection, because what's happened to their white blood cells? They've dropped. Very good. And they have chronic inflammation due to not being able to filter out all the toxins. So if your liver is bad enough, then we need to get rid of it, cut it out, and put a new one in. Now, if you are still actively drinking, will they give you a new liver? If you are still actively using drugs, will they give you a new liver? No. Okay, so you have to show a period of sobriety if that's what caused the liver damage. Now, let's say you get a new liver and then you relapse. Will they give you another liver? No. Okay, so liver transplantation is what we need to fix end-stage liver disease. And we can take out a part of the liver and implant it in, and it will grow to the size that it has available. So transplantation considerations. Do I want to give a transplant to somebody with cancer? No. Do I want a liver that has hepatitis? No. What if I have hepatitis? Will they give me a liver without hepatitis? No. Now, in the past, if you had hepatitis, we just said, no, you can't have a liver. But does it matter if the liver you have, if you have Hep B and Hep C, does it matter if that liver is infected with Hep B and Hep C? It may be in better condition than yours. So we actually will do liver transplants now for people who are infected with hepatitis viruses. But it's not going to be a negative liver. Okay? So we will take a Hep B, Hep C infected liver and put it in a person with Hep B and Hep C. Okay? Now, once I have a transplant, what do I have to do to help prevent rejection? Immunotherapy drugs, right? Immunosuppressants. So they're going to be on cyclosporin. Cyclosporin turns down the immune system. With that said, what happens if they're in a crowd? They're going to get sick. Okay? So you have, remember all the same things that we talked about in hematology with the leukemias? These can come into play with liver as well. Okay, so transplantation complications. Your body can kill the liver. And so that would be active rejection. Okay, so interventions after transplant. How would having a liver transplant affect you psychosocially? What if it was from alcohol? Can you hang out with the same peeps? No. Are you going to be able to go do things that you used to go do? Are you going to be able to go to Fantasy of Trees or to Boomsday with large groups of people? No. Can you go visit your buddy in the hospital? No. So you're tired all the time. You're tied to a drug regimen. So what happens if you quit taking the medications? Your body will reject the liver. So we have lots of long-term management considerations when you have a liver transplant. Now, remember we talked earlier in the semester about what has to match to be able to get a transplant. What kinds of things are those that have to match?
Isn't it like 3 or 4 out of 5 or something?
3 out of 5 HLA antigens have to match. Blood typing has to match. Size has to match. Okay. Okay. What questions do you have? Yes. So. This is not stopping.